When the most commonly reported and the most debilitating symptom of long COVID is fatigue, there's clearly something going on with the condition related to the way our bodies create and use energy. And as I've said before, fatigue as a word doesn't do it justice. No matter what tiredness you might have experienced pre-COVID in your normal life, whether it's from work or exercise or whatever extreme thing you may have been doing, it doesn't get close to the all-consuming critical energy crash that's served up by long COVID. So it's clear that there's something funky going on at a cellular metabolic level. In this film, I talk again to Dr Ade Wentzel, who is on the verge of publishing a new paper looking at the metabolic dysfunction present in long COVID, and perhaps more importantly, how it's connected to everything else, from endothelial dysfunction to platelet activation and microclotting, dysautonomia, mast cell activation, and yes, even erectile dysfunction. There's a reason that no one's really cracked the whole long COVID puzzle until now, and that's unfortunately because it's bloody complicated. So this film too will at times get a little granular. I'm afraid that's just impossible to try and explain what's going on at the metabolic level without breaking it down to the nuts and bolts. So let's dive in. So thanks for joining me again, Dr. Wentzel. It's a pleasure to talk to you again, a little bit of time on. I was just wondering if we could maybe start by, and just basically fill us in on what the last year has brought to you in terms of enlightenment.
Well, I think the most important thing is it's been super exciting for us, just looking at things and just trying to find out where we were going and trying to explain what's going on, because I think the most important thing is that patients need great explanation. So from our perspective, we haven't changed much at all, but we've started to understand, I think, the pathway is better. I think I left you last talking about COVID-induced secondary pellagra. We still are understanding how that's working, and it's brought us to the metabolites, which we think are important, really. So I think that is a big thing. I set out looking at all the symptomatology and try to explain it from a biochemical point of view, and I think that's what we can do now.
So could you just tell us about what your new paper includes as developments from the work you've done previously?
So I think the new paper basically expands on the NAD theory. It looks at NAD, it looks at what the driver of the low NAD is, and maybe at risk, a couple of the risk people, at-risk groups. But then what it does is it tries to explain this inflammatory cycle that we get into and why we can't get out of it. And I think that's the most important thing. And that's been the most exciting part, and how the cycle migrates through low NAD and then uncontrolled inflammatory response, and the management of that uncontrolled inflammatory response utilizing tryptophan to make more NAD, and how those metabolites in between are actually causing all of the problems. I think that's a really short summary of what we've done.
So a lot of the great sort of leading edge research in long COVID is coming out of South Africa. One of your compatriots, Professor Reza Pretorius, obviously recently published a paper talking about her discoveries around microclotting. Could you maybe just discuss how you see your understanding of the condition connecting to those discoveries of microclotting?
Okay, so basically I think we've got to go right back to how it works. So with COVID, we have upregulation of endothelium 2,3-dioxygenase, which is basically a needed enzyme to combat against any kind of infection. The problem in this scenario is that COVID induces that enzyme directly through epigenetic change, and also some of the inflammatory markers induce it as well. And unfortunately, those inflammatory markers aren't choked by the SIRT1 activity, which normally downregulates the tumor necrosis factor converting enzyme and hence the inflammatory markers. We have an upregulation of the kynurenine pathway, and the kynurenine pathway is implicated in many autoimmune diseases, many diseases that we didn't think were implicated. So what it does is it steals tryptophan to make NAD, and in this process, you have all these intermediary metabolites. And I think those intermediary metabolites are where the interrelationship between the metabolites and clotting takes place. I can run through them if you want, just briefly,
Sure.
just so that you can understand. So the first part of it is the formation of kynurenic acid. And kynurenic acid, if you go and if you follow the symptoms and you actually go and have a look why people are getting what, kynurenic acid basically is alpha-7 acetylcholine nicotinic receptor blocker, a huge mouthful. This receptor is absolutely hugely important. It manages a whole bunch of things. Now, what happens with kynurenic acid is it blocks this receptor. It also activates the aryl hydrocarbon receptor, which is really a mouthful. But the aryl hydrocarbon receptor is really, really important for immune response and clotting as well. Kynurenic acid also, we right in the beginning, we were talking about MCAS, mast cell activation syndrome. And we know that the kynurene, that is the precursor of kynurenic acid, activates the mast cell activation syndrome. So that's where you get the symptoms of histamine release. So further down the pathway, we have quinolinic acid. Quinolinic acid has quite a couple of interesting things it does. In high doses, antiphospholipid antibodies, autoimmune antibodies, and again, it can the change of secretions to increased viscosity secretions, and it's also implicated in coagulation abnormalities. Quinolinic acid also is a NMDA receptor agonist, and the increase in glutamate causes cellular dysfunction, sometimes cell death. So that is quite interesting. It also is probably the reason why we have changes in our vision. Probably, if you look at diabetics, we know that quinolinic acid in the lenses and macula of diabetics is high. And we're not sure whether it's causative or whether it's a result of, but my feeling is those groups will be at increased risk during COVID. And then I think the piece that isn't really related is the driver of this big circle of inflammation, coagulation, and metabolic sort of upheaval. And I think that is the CD38. Cluster domain 38 has quite a couple of functions, one being a repair function on the ectoendozyme, but it's also a very important calcium channel function, and is also implicated in platelet activity as well. So when you're looking at clotting, you can see that they all sort of go together. If you're looking at conditions that are linked to the kynurene pathway, I'm looking up against the wall because there's so many, so I've got a crib note up there. You're looking at a lot of autoimmune disease, SLE, Sjogren's, Alzheimer's, rheumatoid arthritis, Parkinson's, Ehlers-Danlos, amyloid sarcoid cancer, multiple sclerosis, Huntington's, anxiety, and it just goes on all the way down to HIV, cognitive disorders. And right at the bottom, there's a good chance that you're going to be looking at things like fibromyalgia and ME syndrome, because I think that the pathophysiology is going to turn out to be exactly the same. Same as people with long-term Borrelia infection. We know that those pathways have been measured to be up, and those metabolites are what causes very similar symptoms to what we see.
So I mean, it's interesting what you say there about CD38 and leading to activated platelets, because the cycle that's been discussed, as far as I understand it, amongst that microclotting paper, is that you've got this cycle which leads to hyperactivated platelets that lead to excess clotting, and then the clotting is antigenic, and then that sort of reactivates the platelets. But if there was another driver that feeds in from an adjacent vicious cycle that also hyperactivates the platelets, like something like CD38, that would actually link a lot of this together and make a huge amount of sense to me.
Well, I think it all fits together. I think the first thing you see in oxidative stress, we have the glycocalyx of the vessel. Glycocalyx is like a very soft, fluffy cotton wool lining that keeps the cells away from the endothelium. And what that does is it prevents them being activated, the platelets being activated from the contact. Oxidative stress often strips that. We know in anesthesia that if you stress the vasculature, then you get rid of this endothelial glycocalyx, which exposes all of the things that start clotting, inflammation, and you get a platelet interaction. From that, you get clotting cascade activity, and it goes on and on. In this scenario with the high CD38, it's exaggerated. Then you've also got the action of the aryl hydrocarbon receptor that's thrown in. And then if you looked at I mentioned about Amyloid being a very interesting condition related to the kynurenine pathway. These are amyloid type clots. There's a resistance to fibrinolysis, and it's probably from the amyloid side. So it all really does tie together very nicely.
So one of the other observations from the clinics out in Germany, where they've been doing a lot of the HELP apheresis, is as part of the process, they take a venous oxygen saturation reading before they do the procedure, before and afterwards. And what we've tended to see amongst long haulers is a particularly low venous oxygen saturation. So obviously, I think the median is mid-70s, something like that. But we're often seeing results down in the 20s, 30s, 40s quite frequently. So this tells us that something on a metabolic side, in terms of how the cells are using their oxygen in the tissues, is abnormal. And I was wondering, I was sort of postulating that is there something going on here where we've got this basically cellular metabolism that is functioning in an anaerobic fashion rather than aerobic fashion? This is leading to a very poor ATP generation, which then might feed into possible post-exertional malaise, because actually we physically don't have the ATP to run the body. I was just wondering if that makes any sense to you, and what you might say about that. Yeah.
Absolutely. It's exceptionally interesting you say that, because we know that if you have low NAD, that you're going to probably cycle towards the glycolysis side. We also know that you generate probably 1/15 of the energy from glycolysis.
A quick intervention here for those of you who haven't just sat a biology A-level. Glycolysis is the first step of generating energy out of glucose and oxygen. It breaks down glucose into pyruvate, and it creates 2 units of ATP per oxygen, ATP being sort of the fundamental unit of energy in the body. However, this is a relatively small part of the energy generation process. The Krebs cycle generates 2 more ATP, and then finally the electron transport chain can create up to 34 ATP more. So basically, glycolysis alone clearly can't move the needle that much, and we rely on many other parts of the metabolic process for most of our energy. Back to the interview.
The other thing you probably don't realize is that cells, especially immune cells, you're looking at the monocytes, macrophages, T cells, they change their function. And the functionality is changed by whether they use glycolysis or whether they use the Krebs cycle. If they use glycolysis, they become pro-inflammatory. And if you look at the markers that go along with those pro-inflammatory, you're looking at tumor necrosis factor, interleukin-1 beta, gamma interferon, interleukin-6, 12, 23, and COX-2 activity. So they're pro-inflammatory. We know that. So this is how the autoimmune system is probably being changed, that we are moving, and by changing how the cell behaves, you probably are changing the function of the cell. And we know that human immunity is relatively poor. T cell immunity goes through a lot of changes. And not only is it related to glycolysis and Krebs cycle, but it's also driven by IDO, indolamine 2,3 dioxygenase. And that indolamine 2,3 dioxygenase also is compounding this problem. We also have the high CD38, which once the high CD38 is there in a milieu of high gamma interferon, what you get is you get lipid peroxidation as well. That lipid peroxidation generates more inflammation, more gamma interferon, and the circle goes nastily round and round. So that your observations are absolutely correct. On the muscle side, you're going to get sore muscles and lactate, but on an immune side, you're going to have pro-inflammatory. Just remember that the way these cells work is they balance pro and anti-inflammatory. We need pro-inflammatory cells under certain circumstances to counteract infection. But too much of them is what gives you this chronic type of a picture. And we are always, our bodies, even with coagulation, we are balancing procoagulation with anticoagulation. Areas that are need to have clotting have an increased coagulation, but other areas are being anticoagulated. So there's always a balance. And I think what's happened with long COVID is that we've fallen out of balance from an inflammation type of setting.
How do you go about showing evidence of this sort of metabolic disruption? How do you get to a point where you can prove that it's going on? Like, how do you go about doing that?
Well, it's pretty easy. You can look at the symptoms really, and from there you can work out exactly what is going on. But I think the first things that you can see, we know that there's a metabolic disruption. Okay, so we look at the measures. Certain groups have measured low cellular NAD as much as 85% down. That's massive. Okay, we've measured inflammatory markers, gamma interferon, tumor necrosis factor alpha, interleukin 1, interleukin 6. Those are all have been measured, and there's studies that you can go and look. There's also studies that look at a cellular side of looking at VO2 max, the maximum amount of oxygenation that the body can use. And it really looks at the cellular. And basically what they found there was that our VO2 maxes go down about 25%. I think mine went down from 42 to 35, just as an indication that it's actually a real thing. So we know those were invasive cardiopulmonary patients that had long COVID that they actually measured. And then we can look at the literature from mitochondrial injury, mitochondrial myopathy. There's a huge amount of literature, quite a bit on the therapy of that with nicotinic acid. And then we can also look at autoantibodies. We now know that roughly 50% of long COVID patients, autoantibodies are present, and that's really is massive. Just remember that those autoantibodies are probably the ones that can cause clotting and coagulation in things like SLE and other autoimmune diseases. So yeah, I think there's a lot of evidence to support what we're saying.
How is this linked through to dysautonomia in POTS? How does this? How did we get there?
You can see I'm sitting forward. I'm starting to get excited here because I think that was probably one of the biggest realizations. So we looked at COVID-induced pellagra, okay, and it's really a form first of COVID-induced pellagra. We went to the pathways, and then what we did was we found the carnurenic acid, but I didn't find the carnurenic acid with it causes POTS and dysautonomia. What I did was I spent a lot of time speaking to patients with going backwards and forwards, trying to equate symptoms to biochemistry. And the young kid said to me, you know what, this is POTS and dysautonomia 100%. He's not even sure that there's a thing called long COVID. He had POTS and syndrome. And then I went to look back at the causality of POTS, looked through molds, and eventually I came up with the same thing, carnurenic acid. From that, I was able to go and see what symptoms might be related to carnurenic acid block of the alpha-7 acetylcholine nicotinic receptor. And there it was. It was the alpha-7 acetylcholine nicotinic receptor is the main receptor of the autonomic ganglia that manages your heart, manages your vasculature. And if you block it, then basically you get very similar to what a diabetic has. Now, if we go back to finding carnurenic acid in the lenses and quinolinic acid in the lenses of diabetics, it starts to diabetics also suffer from dysautonomia. If they have uncontrolled diabetes for more than 5 years, we often see persistent tachycardia, exactly the same things as what we're seeing in long COVID. So the dysautonomia, in my opinion, is related to the block of the alpha-7 acetylcholine nicotinic receptor. And the brain fog, in my opinion, is exactly the same because, believe it or not, memory function is the main receptor. There's the alpha-7 acetylcholine nicotinic receptor. So you might say, well, there are two receptors. What else could it possibly be causing? Well, it's going to probably be causing the bladder dysfunction that we're seeing in long COVID, the irritability. We're also going to be seeing erectile dysfunction because I know that definitely in animal studies of the corpus callosum and the rectal function in animals, that receptor is found there again. So where you start looking and there's commonality, the chances that you're wrong are pretty much zero, I think.
So one of the conversations I've been having recently is about why the long COVID clinics in the UK are struggling so much to make any traction in terms of helping patients, in terms of working out what's going on. And it seems to me that Western medicine generally exists in these sort of siloed specialties where you've got your neurologist, your cardiologist, your respiratory specialist, and the rest of it. And they all look at each, they look at a patient, they come in and they look at those symptoms and they try and apply those symptoms to their paint by numbers. I'm being a little bit reductive here, so apologies to any consultants who may be watching this, but they apply that to their sort of paint by numbers. Okay, what do these symptoms add up to all of the conditions that existed pre-COVID? And they don't really fit and they get a bit flummoxed. And then the next specialist looks at it and it doesn't quite fit with him either. They try and sort of go, well, it looks a little bit like this, it looks a little bit like that. But really, to be able to understand what's going on with long COVID and to a degree ME/CFS, you almost have to take all of these little paint by numbers 2D sheets, put them up into a 3D stack and take a step back. And rather than looking at them in a 2-dimensional way, look at it in a 3-dimensional way across every single system. And you've got this connective space, both figuratively and literally, because it seems like connective tissue is also implicated in this as well. And it's in those gaps where actually long COVID lives. And it's in those gaps, which I think is where the metabolic side of stuff, which has often been ignored when it comes to looking at what might be causing this, which has the answer. I don't know if that makes sense to you, or if you'd agree with that.
Yeah, well, I think you're absolutely right. So you say, so how did I get into it? Well, I got it. So I was one of the first and I needed to find out what the hell is going on. So I was super interested because I could see trouble down the street with this. So that's, I mean, I've got psychiatry background when I did that in the UK in the late 90s. I'm an anesthesiologist. I've got CART. I've got most of the things. And I want to find out what's going on. And from a statistics background, for me, I wanted everything to fit into one bag. So that's what when we started, I started to look at why people were dying in the acute setting, and we found that, and then I looked at why some people are more at risk than others, and we found that. Then we looked at why NAD was important when it came to SIRTs and inflammatory response, and we found that. And then we went to how it moderates the tumor growth factor converting enzyme, and then from there we went to what tries to save it, and the kynurenine pathway is really trying to save this whole thing from falling flat. If it wasn't there, we probably would die. We would probably have an uncontrolled immune response, inflammatory response, and would probably pass away. But the pathway is super clever. So it's basically saving us at the risk of having all symptoms. So it's a double-edged sword, really. I think that when you're looking at why it's so difficult, it's super difficult to explain. Someone was saying to me, you know what, explain it to me in one line. And I said, it's taken me a year to write, just to put up one flow diagram so that everyone can understand it. Then you've got to explain it. I think I was super motivated to try and put every single symptom that I had, or that I wanted to know, why did your secretions become thick and sticky? I wanted to know, why did you get tinnitus? I wanted to know bladder. I wanted to know everything. So that's how I came to look at it from that perspective. I think my wife might divorce me after this because I became obsessed with finding this. It was like Sudoku. I played it ongoingly for thousands of hours. Why do the clinics struggle? It's because no one's really put it together, and that's what I'm hoping that in this paper that we put together, that's coming out, explaining the flow diagram, which I hope you will post. I think that makes it very easy for people to understand that we're not dealing with a psychiatric illness, or we're not dealing with this or that. We're dealing with something that is fully inclusive and really is something that we need to manage as fully inclusive. I think that's the plan.
I mentioned connective tissue in that, and I saw your eyebrows go up a little bit. What role do you see with connective tissue in all of this? Because it has become a bit of a hot topic recently as well.
Connective tissue, 100. Well, I mean, the conditions linked to the kynurenine pathway, all the connective tissues diseases are there, and I can throw in some other nice ones like multiple sclerosis, or bad ones like multiple sclerosis, Huntington's, and I'm sure that if I look close enough, that we will see ME and chronic fatigue syndrome and fibromyalgia, because I can already see the cognitive disorder of HIV in this. So I think. So you might ask, well, how does the connective tissue part fit in? and basically it's related to the quinolinic acid. Those connective tissues disorders that are implicated in long COVID all have quinolinic acid as a marker. Now, when you look at the studies, they don't know whether it's a cause or an effect of, and I think it's a cause rather than an effect, whereas people have been measuring it as an effect. We have SLE, therefore our quinolinic acid is high. My feeling is that we have an autoimmune disease because of abnormal activation of the kynurenine pathway with increased quinolinic acid. I think that's a better way of looking at it. And if you look at all the autoimmune diseases, they all really string together. You can sort of see them as one continuum, in my opinion, some related to slightly different subsets of connective tissue.
What's your position on viral persistence? As time has gone on, we've had more and more studies coming out, which are all, we haven't quite found the smoking gun because those studies haven't been done, but we've found a lot of circumstantial evidence that points to the possibility of there being viral reservoirs that may just be sitting there and just spitting out bits of viral debris potentially, which is driving this whole system of inflammation and reaction. I don't know where you sit on this topic.
So I sit and look at it and see it's a total, it's absolutely a possibility, because what I look at it is from the perspective of what my research shows. Is it possible? Why would it happen and why wouldn't it happen? So there's two parts of viral persistence. We got to decide whether we have viable virus, and I'll explain to you that. And we've got to worry about viral particles and whether they are driving the immune response. From a viral material point of view, I'm sure there's going to be viral material, and I'm pretty confident, because we know that SIRT1 is what drives autophagy. Autophagy is the ability to rid the cells of cellular debris. Okay, that's NAD dependent. So on that side, I'm quite happy with this. From a viral persistence, it's quite interesting that beta coronaviruses that have been looked at before have the ability to try and escape the body's what would you call it, the body's ability to get rid of them. And what do? They basically have found a way to hide against the tumor suppressor gene P53. Tumor suppressor gene P53 is an ability to either repair viral damage or to close the cell down in programmed cell death. Now, the question that I have, and it's not my field, is that whether these aren't a subset of people with low P53 that might be at risk. And it's quite interesting to see that CD38 and P53 are also tied together. High CD38, lower P53. Lower P53, you're going in with a virus that's hiding from P53, okay? And you've got a lower P53, so there's a much greater chance of it being able to hide. So yes, I believe that there's probably cases where both scenarios are present. Do I believe that it's in every single case? No, I don't. I think that there's a varying degree of in the spread of disease from just a initial low NAD that responds pretty quickly if you catch it early post-COVID, all the way to viral persistence. And then if you're looking at metabolic pathways, you can always go onto autoimmune problems, spots, more brain fog than usual, and so forth. So it depends on what the person's physiology or metabolism behaves like. But I think everyone has very different responses across the board.
So in terms of what we do about this, we discussed a treatment stack last time.
Yeah.
I was just wondering if there's any evolution to that stack over time in terms of what your recommendations would be.
So when we look at the treatment stack, basically the mainstay is nicotinic acid, and people will say, but it gives me a flush, but that's what we aren't wanting the flush, but the flush is actually beneficial on a numerous, and I'll explain to you in a moment. The nicotinic acid basically works via the price handler pathway, and basically putting in in substrate into the side of the kynurenine pathway right at the end. So it has the possibility of decreasing that kynurenine pathway, as opposed to other precursors of NAD that utilize the salvage pathway. And those precursors are broken down by high CD38s even before they get into the cell extracellularly. What we see when we're treating with nicotinamide, NMN, and NR is that the patients don't seem to get 100% well. And when I say 100% well, I'm meaning 97% well, because that last 3% is an exceptionally difficult thing to attain. We then use a combination of quercetin and resveratrol, because we found that if we were driving big doses of either, then we'd have side effects. So really, the quercetin is looking at trying to drive up the NAD and decrease the CD38. The resveratrol also trying to increase the NAD. And then we utilize quadrifolic, folate, methyl 6-methyl tetrahydrofolate. You can use 5-methyl tetrahydrofolate. Two functions. One is supplies methyl groups for the function of the NAD, and then the folate part of it also counteracts the quinolinic acid. So that's just a few of the components. D3, we know that D3, B6, and B12 are actually all vitamin or all NAD dependent. If you don't have them, the D doesn't go from 2 to D2 to D3, and the B6 and the B12 are also very important, that your NAD level is high to utilize them. So that's sort of what we've tried to achieve. So that's really how we play the game, really.
So the most common question I get on the last film we made was, why can't I just take NMN or nicotinamide? Loads of people I know got much better with it. Are we looking at a scenario where nicotinamide helps, but nicotinic acid helps more? Is that sort of...
Well, there's probably, so really, so if you're trying to get 100% better, so the biggest thing that I have is trying to get people that are on nicotinamide better. And generally what we have to do is we've got to take them off and move them onto nicotinic acid. And you'll see that in the last part of both of those pathways, the same enzyme is utilized for nicotinic acid and nicotinamide. Remembering that those are all utilized through the salvage pathway. So it salvages utilized NAD and it makes it back into new NAD. In this pathway, the price handler pathway, what we're doing is we're putting in original substrate just before NAD, and it's a totally different pathway. And it is related to that kynurenine pathway. And the nicotinic acid adenine dinucleotide that has been formed probably will be having a negative feedback effect on the initial, on RDOs, such driving the pathway. Do patients get better? Yes, they do, but they don't get 100% better. They probably stop at about 60% from what we can see. They're not getting right up to where we want them to be. Also, that NAD, if you're going to have a look at it from it's quite interesting. If you're going to have a look at it from there's from a perspective of what supplies NAD and ATP energy. Nicotinic acid does it by far the best in the heart, the brain, and the kidneys. So it doesn't only make NAD, but it makes NAD and ATP, whereas some of those others do not. We probably best talk about the pleiotropic effects, the effects from the vasodilatation, the receptor that drives the vasodilatation, the GP109A receptor. And we know that there's now a lot of studies coming out with what we call pleiotropic effects that aren't related to the direct effect of the nicotinic acid. And those effects are great for cardiovascular and a lot of areas, heart failure, arrhythmias, and things like that are being looked at from a nicotinic acid point of view.
If you were given, I don't know, if you won the lottery and the condition was you had to spend it on a research project, what would you like to do?
I think we don't even have to win the lottery. I think that it's highly attainable even with small budgets. So Professor Guy Richards and myself are at the moment putting together a study to measure the kynurenine pathway, to measure the drivers, IDO, and things like that, as indicators of long COVID. And I think what we will find from there will determine how we manage it and see whether we can actually find a marker that gives us exactly tells us about the response, because that's really what the patient want to know. They want to know, my markers are going up or my markers are going down. I'd also like to see linking up of measurements of these metabolites in the samples for clotting, and the debate about whether, if you don't treat the cause of some of these metabolites, whether the clots won't reoccur, because my feeling would be that they'll probably just be back after a couple of months. So you're either going to have to anticoagulate or you're going to have to treat the cause, and my feeling is we can do both, and I think we're going to win on that side. So there's lots of stuff. I don't think we need to win the lottery. I just think we need to back quite clever. It is difficult getting funding, but I think we can get there.
Thank you so much indeed, Dr. Wentzel. It's been an absolute pleasure talking to you again. When's your paper going to be available for people to read, and where can they find it?
At the moment, I'm just still trying to get the last diagram finished, but it should be out in the next couple of months. We finished writing the article, so there's a preprint that I'm quite happy to let people see if they want to look at that. It hasn't been peer reviewed as yet, but if you can find holes, we're happy to talk about those, because we're not really scared if there are holes to look at it again. So hopefully we're out in the next couple of months. We just need to find someone that's going to publish it for us.
Perfect, thank you. What's fascinating for me is starting to see all the sort of pieces of the jigsaw puzzle come together. Admittedly, we might not have all 1,000 pieces of the jigsaw puzzle for long COVID on the table. Some of them are back to front, some of them are on the floor. The dog's maybe eaten a couple of them, but we are starting to see some of the shapes in this picture coming together, and some of the detail in the corners and along the sides too. What's going to be fascinating over the next 6, 12, 18 months is filling in the rest of this jigsaw puzzle as more research comes out and starting to see more of the bigger picture. And of course, along with that comes better ideas about what might work regarding treatments. Now, speaking of treatment, if you're wondering about the efficacy of niacin, that's vitamin B3, nicotinic acid, and whether it does help long COVID symptoms, I made this film last year based on a study I did of 812 long haulers. I highly recommend a watch. So look after yourselves until next time.